My name is Richard Beasley, and my task today is to give a brief overview of the new Adult Asthma Quick Reference Guide, Asthma Guidelines. To put the guidelines in perspective, these were developed by a multidisciplinary group of specialists. They were convened by the Asthma and Respiratory Foundation of New Zealand, and they were drafted independent from the pharmaceutical industry. The purpose of the guidelines were to provide simple, practical, and evidence-based recommendations for the diagnosis, assessment, and management of adult asthma, mainly for primary care. And so if we start with the diagnosis of asthma, this is relatively straightforward. It's based on the recognition of the characteristic grouping of symptoms, followed by a clinical examination, and then lung function test, in particular, the demonstration of reversibility. If perhaps there were two key points to make in terms of the diagnosis, the first is that no cut point is provided in terms of the reversibility of lung function or the variability over time that would indicate the diagnosis of asthma. And the reason for this is there is none. That there's considerable overlap in terms of bronchodilator reversibility and peak flow variability, not only between asthma and COPD, but also in terms of the normal healthy adult population. However, it's clearly stated that the higher the degree of reversibility or peak flow variability, the more likely the diagnosis of asthma, and the less amount of bronchodilator reversibility or peak flow variability, the less likely there's a diagnosis of asthma. And I think the other key point is that a therapeutic trial of asthma medication is a really important part of the diagnostic process. And if there's a poor or little response to standard asthma treatment, then in addition to doing other things like checking inhaler technique and compliance, there may be the need to consider alternative diagnoses. So once the diagnosis of asthma has been made, the next priority is to assess the level of asthma control and also the risk of future severe exacerbations. You're all familiar with the Asthma Control test, which has been very well validated in terms of a measure of asthma control. And I think it also has the practical advantage of allowing the patient to self-assess their asthma control by completing the questionnaire before they attend their doctor's appointment. And then it's a very good basis in terms of starting off your consultation in terms of the assessment of their asthma control. Now, as with any continuous measure in medicine, it's difficult to determine exactly where the cut points are and how they should be interpreted in terms of leading to a change in treatment. But having said that, if a patient has an ACT score of 20 or more, they clearly are well controlled and have stable asthma. If the ACT score is 14 or less, then very clearly they have poorly controlled asthma and are likely to need an increase in their baseline asthma treatment. And between those two levels of 14 and 20, it is somewhat of a grey area and will need some interpretation by the clinician in terms of whether a therapeutic response is required. Another important part of assessment is the identification of patients who are at high risk of a severe exacerbation, and there are a number of ways in which this can be achieved. Perhaps one of the simplest is monitoring their healthcare utilisation, for example, a recent hospital admission or acute presentations to after hours or to the emergency department, or actually if a patient has ever had an ICU admission. Another practical way is to monitor their medication requirements. A patient who has had a number of courses of oral steroids for severe exacerbations. A patient who frequently requests repeat prescriptions of their beta-agonist inhaler. And certainly those patients who disproportionately get repeat prescriptions for their beta-agonist inhaler compared to their requirement for inhaled corticosteroids. And if we can turn now to the continuous cycle of assessment that has been developed within the GINA guidelines. Following the diagnosis of asthma and the assessment of control and future risk, one then prescribes their medications appropriately, and there may be some need for some non-pharmacological measures, in particular to identify modifiable risk factors. One then assesses the response to treatment, and then with further assessment that would always include assessment of inhaler technique and compliance, and taking the patient preference into account. And then we come to the really important issue: at what stage do we initiate inhaled corticosteroid therapy? So in New Zealand we have followed our guidelines, we have followed the international guidelines which recommend that inhaled corticosteroids should be considered when a patient is having symptoms at least twice per week, or if they're using their short-acting beta agonist on at least 2 occasions per week. Also, if they've had a severe exacerbation of asthma, that would be the requirement for inhaled corticosteroids to reduce the risk of a further exacerbation. And so the next question is, at what dose should one start inhaled corticosteroid therapy? And to really go through this, I'd like to briefly mention that the traditional approach of classifying inhaled corticosteroids as low, medium or high dose has now been replaced by a far simpler and more evidence-based system where we consider standard doses and higher doses. Now, in terms of standard doses, beclomethasone dipropionate BDP at around 400 to 500 micrograms per day, the extra fine BDP at around 200 micrograms per day, budesonide at around 400 micrograms per day, and FP or fluticasone propionate at around 200 to 250 micrograms per day, depending on the inhaler device. Now, these are considered the standard doses of inhaled corticosteroids, and these are the doses one would initiate treatment with, and also the standard doses to use in patients, even those with moderate to severe asthma. And so very briefly, the evidence on which these standard doses have been recommended. Well, first of all, in terms of the initiation of therapy, it's been shown repeatedly in clinical trials that these standard doses achieve the maximum obtainable benefit that can be obtained with inhaled corticosteroids. And that even if one used 2 to 4 times higher doses, one would not obtain any better control, and all you'd be doing is exposing the patient to a greater risk from the side effects of high-dose inhaled corticosteroid therapy, and then expose patients to ongoing inappropriate high-dose usage. So we now need to turn to the situation of moderate to severe asthma and consider what is the therapeutic dose-response relationship of inhaled corticosteroids. If we take fluticasone propionate at the top x-axis, that 80 to 90% of the maximum obtainable benefit is achieved with doses around 100 to 200 micrograms per day. And this is for all major clinical outcomes, including severe exacerbations. And that the maximum obtainable benefit is achieved at around 500 micrograms of FP per day. And if we look at budesonide at the lower x-axis, we can see that 80 to 90% of the maximum obtainable benefit is achieved with doses around 200 to 400 micrograms per day for all the major clinical outcome variables, and that the maximum obtainable benefit is achieved at around 1,000 micrograms per day. So we can see why the doses of around 100 to 200 of FP and around 200 to 400 of budesonide are considered the standard doses, and doses higher than that should be considered high doses. The next issue to consider is if a patient is not adequately controlled on a standard dose of inhaled corticosteroid therapy, how does one add a long-acting beta agonist drug, a LABA? I think the most important point to stress is that a LABA should always be prescribed as a combination inhaled steroid LABA inhaler, and that one should never prescribe in an asthmatic patient a LABA as a separate inhaler. And the reason for this, as we all are well aware, is that for patients who are prescribed a separate inhaled corticosteroid and a separate LABA inhaler, there will be periods with poor compliance or non-compliance with the inhaled corticosteroid, often for prolonged periods of time. And during those periods, if they still take their LABA for symptomatic relief, they'll essentially be taking LABA monotherapy, which is associated with an increased risk of mortality. And we can look at it around the other way as well, that we know that when you prescribe an inhaled corticosteroid as a combination inhaler with a LABA, that the patient will take more inhaled corticosteroid because their greater use of the LABA-containing inhaler will lead to greater compliance. The other important point to note in terms of ICS-LABA combination therapy is that there are 2 regimes that can be used. What is traditionally called the standard regime, where the ICS-LABA combination inhaler is used for maintenance, and a short-acting beta agonist such as salbutamol is used as reliever therapy. The other regime is called the SMART regimen, and that uses with the use of an ICS fast-acting LABA as a combination inhaler, both as maintenance and also because it has a fast onset of action of the LABA component, can also be used as reliever therapy, and that is called the SMART regime. And the evidence suggests that when you use an ICS LABA in accordance with the SMART regime, it is more effective in terms of reducing the risk of severe exacerbations. And we can see this in the summary data from the New Zealand study, which looked at budesonide and formoterol, both as maintenance and reliever therapy. The SMART regime, the rate of severe exacerbations over the 6-month course of the study, and that's in red at the top, and that's compared with the same budesonide formoterol combination metered-dose inhaler used for maintenance and salbutamol used for reliever. And so the SMART regime resulted in about a 40% reduction in risk of a severe exacerbation. If we look at data from the study in Maori who have a greater burden from asthma, the reduction in risk with the SMART regime was similar to those non-Maori participants in the study. And so the SMART regime can be considered with a preferred regime for Maori as well as non-Maori at risk of severe exacerbations of asthma. And so the asthma guidelines are clear that the SMART regime is more effective than the standard ICS LABA combination therapy with a short-acting beta-agonist as reliever in the treatment of adult asthma. And it recommends that the SMART regimen is the preferred regime for the treatment of patients with severe asthma at risk of exacerbations. And so we can use this knowledge of the medications in asthma to develop a strategy based on stepping up to achieve and maintaining control, and stepping down in terms of treatment requirements for a patient who may have very well controlled asthma for a sustained period of time. And so if we start at the left, a patient with mild or intermittent asthma, they may be started in step 1 on a short-acting beta-agonist as a reliever therapy only. However, once they get symptoms at least twice per week or have had a severe exacerbation, they would then step up with the introduction of inhaled corticosteroid therapy at a standard dose. And for most patients, this step 2 with regular maintenance standard inhaled corticosteroid therapy with a short-acting beta-agonist as a reliever will be quite sufficient to maintain control of their asthma and reduce the risk of severe exacerbations. If, however, there is inadequate control, then one would step up to step 3, which would involve the addition of a long-acting beta-agonist drug within an ICS LABA combination inhaler, and this could be prescribed in one of 2 forms. What's traditionally called the standard approach, where you use the ICS LABA combination inhaler as maintenance and a short-acting beta-agonist as your reliever therapy, or the SMART regimen, where the combination inhaler is used both for maintenance and relief. And in New Zealand, that is only approved for use with the budesonide formoterol Symbicort Turbihaler preparation. There are very few patients that would then not be adequately controlled. However, if that is the case, one would step up to step 4, where one uses a higher dose of inhaled corticosteroid within the ICS LABA combination inhaler, and once again that can be prescribed according to the standard or the SMART regimen. And for the very few patients who are not adequately controlled at step 4, you would then consider the addition of additional therapies and may also be the requirement for specialist medical review. I will leave the presentation at this stage. In part 2 of the presentation, I will cover how one can implement this strategy for asthma management with individual patients within the asthma self-management plan system of care, and also look for the patient with more severe asthma, how one can use precision medicine for a more individualized approach in an attempt to achieve better asthma control.